Yep. Okay.
So we have 37 participants. We can start anytime.
Okay, thank you. Well, good morning or good afternoon, depending on what time zone everybody's in today. Thank you for joining us. This is our final MDS webinar today in a series of webinars. You can locate the past series recordings on the website for Mountain-Pacific. Those will soon be available. So be sure to catch those if you missed any of the sessions that Jennifer's provided for us. You will have the ability to unmute yourself, but please keep yourself muted in the meantime. You can also enter questions and comments in the chat box. So what I'd like to do next is introduce our guest speaker, Jennifer LaBay. Jennifer LaBay is a registered nurse. She has a lot of certifications in RAC. I'm going to read these out because I don't understand all of them, so I want to make sure she gets credit for all the hard work she did to obtain these. So RAC-MT, RAC-MTA, and CRC is the MDS policy consultant for Triad Healthcare in Providence, Rhode Island. She is also an AAPACN training partner and AANAC master teacher as an independent contractor with JLB MDS Consulting in Pawtucket, Rhode Island. She has been involved in the RAI process since 1997 and has been in the long-term care industry since 1991, serving in a variety of capacities, including CNA, charge nurse, MDS coordinator, and regional corporate clinical reimbursement specialist. Jennifer has a considerable expertise in the MDS, RAI, PPS, and ICD-10, including the clinical and financial aspects. She has a knack for making her seminars as an enjoyable learning experience and readily makes herself available to all attendees of her programs for any follow-up questions that may arise long after the seminar is complete. So Jennifer, it's been a pleasure working with you over these past many weeks and months. And with that, I'll turn it over to you now.
Well, thank you once again to Mountain-Pacific for having me. It's really been lovely to be with you and to be a resource for you, because that's really what it's all about, is having somebody to go to help kind of, dive into the craziness that is our whole MDS and RAI process and all of the spokes of the wheel that go along with that. And I know a lot of our focus has been quality measures during our presentations, and I hope that I've been able to clear the muck a little bit, if you will. So as Jill said, if you have any questions, you can click on the raise your hand, and then that will allow us to unmute you, and you can just kind of shout out at me. I'm very informal, or you could just write in the chat, in the chat box as well. So there was a couple of questions that came in since our last presentation that I figured I'd get started with in case people needed some time to throw their question into chat if they didn't want to speak to the whole group. The first one I'm going to address was asking about the SIG change. So somebody asked a question about a significant weight loss, and it was documented at the 6-month and 1-month mark. And should we do a SIG change with that? Is that a requirement? Well, the answer to this kind of varies. It's really going to be patient specific. The whole point of what the RAI manual indicates for determining when a significant change in status is basically you have to use your clinical judgment. You have to look at what else is affecting this resident. Now, certainly, one area could signify a significant change, but starting on the RAI manual, page 2-24, there are some guidelines about should we do this as a SIG change or not. If a condition is self-limiting, they have the flu, they had a little bit of weight loss, and that's actually one of the examples they give in the REI manual, was a 5% weight loss. And that's expected because maybe they had, some GI issues, some diarrhea, some nausea, some vomiting, and perhaps a weight loss would be expected. As long as the care plan reflects what is going on. If that's the only change, it's not necessary to do a significant change in status. Like I said, as long as the care plan and the medical record truly tells the picture of what's going on with that resident. One thing you'd want to look at, though, is if they've had that weight loss, is there anything else going on? Have they developed any other declines that may also impact their need for a significant revamp of their care plan? And essentially, their baseline is different. And it's something that's not going to resolve within 2 weeks, because that's ultimately what we're looking at is that 14-day time frame. Now, certainly, if there is only one change, and that's something pretty significant like a weight loss or maybe a wound, it is going to be up to the team to determine if that would be beneficial for the person to have a significant change in status, because then that would require a full overview, their care area assessments, their care plans. But every situation is unique. What might be a sig change triggers for one might not be a sig change trigger for another person, depending on all of those other factors, comorbidities and issues that might be going on with that resident. So it really needs to be a team decision, interdisciplinary team decision as to whether or not they're going to benefit from that significant change in status. You would then want to document your rationale in the medical record. I find that's a piece that's missing a lot in regards to any significant change in status, whether it meets the 2 areas of decline or improvement, or it's just a one area, is we're not really documenting in the medical record to determine, okay, we have determined that there's a significant change and here's why, because that's going to set your time frame for determining when that significant change in status is due to be completed. You have 14 days from the date that you've determined the sig change is required to then complete that assessment and the cause associated with that. But a lot of times we miss that and forget to document that here's the date that we're determining a sig change is required. So there's no way to tell when that assessment is due. Your software isn't going to tell you because your software doesn't have that as a scheduled assessment. It's an unscheduled assessment. So it's not something that it's going to trigger to you and say, hey, you have to do a sig change now. I mean, you may have some smart scrubbers and some outside third-party things that might be helpful. If they do a review of your medical record, there's all sorts of things out there. But if you don't have anything other than just your standard electronic health record, it may not tell you that. So that's an important piece to make sure that you're documenting in the medical record that a sig change is required and why you plan on doing it, if they meet the criteria, if they don't meet the criteria. My rule of thumb is if you're questioning it, whether you should do one or not, I always err on the side of do it, because then you have that, there's no question. You're doing a full review. It's not going to hurt to do extra reviews. Certainly being able to take a closer look at that resident and make sure that their care plan is up to snuff as far as their accurate current condition is never a bad thing to look at them more often. The next item that came in as a question, and thank you for sending those questions. For those of you individuals who actually did send me these questions, I did also send you an email response. I like to make sure that you have your questions answered, and if there's anything that I missed, I want to make sure that you have a full understanding of what my answers were. And I'm always available. I love answering questions. I was talking to Mary before we started the session, even if we don't have anything in an official capacity, throw me a question. It'll usually take me a very short time to get you that information. I'm very happy to share. My goal is to make sure we're all on the same page and that we have all the same understanding. So another question that came up, a little bigger in scope, not that there's, the sig change determination is small by any means, but this question goes along with the current public health emergency and the waivers that are associated with that. So the question came in initially asking about the different waivers that are available regarding the 3-day qualifying hospital stay and the benefit period waiver, looking at when do these apply? Do they have to be related to COVID directly? And when do we have, what can we do? So I just wanted to share with you a couple of the documents that are out there. So let me find it on my screen. I have so many screens open. Let me share with you what I've got. So this is the first one. So this is a Medicare Learning Network Matters. The number of this document is SE 20011, and this was put out most updated recently on November 9th. So this is giving us a little more information about the different waivers and what has to be in place to meet the criteria for those waivers. And then a little later in the document is how to bill for them, because there's certain billing criteria that has to be met, especially if somebody is exhausting benefits and continuing on. So just, I could probably, take the whole rest of our time, and I don't want to take the whole rest of our time on this one question, but this is a very nice document in that it gives you the detail about what the waivers entail. So we've got two big ones. The qualifying hospital stay waiver. This is for all beneficiaries of Medicare. It doesn't have anything to do with them having COVID-19 directly or even indirectly. So there's a lot of discrepancies out there, if you will. Even a lot of experts are in some disagreement as to the ability to utilize this part of the waiver. But this says it right here. All beneficiaries qualify regardless of whether they have any SNF benefit days remaining and the beneficiary status of being affected by the emergency. And that's a lot of times what people, myself included, because I keep vacillating back and forth since this came out. Affected by the emergency. So some people interpreted this as the hospitals have to be to capacity, or there has to be a reason why you can't send them to the hospital related to the emergency. This is a nationally declared disaster, basically, public health emergency, and the status of being affected by the emergency exists nationwide. So this, applies to everyone, the entire nation. You don't have to verify the individual cases. So I think there's a little more flexibility in accessing this part of the waiver, which is they don't have to have that 3-day qualifying hospital stay in order to be covered using this waiver. As long as they meet a daily skilled criteria that meets all of the Chapter 8 of the Medicare benefit policy requirements, as long as they meet that criteria in your facility on a daily basis, this qualifying hospital stay waiver can be applied. The second piece of the puzzle, which is kind of what the question really directed at, was this benefit period waiver. So folks who exhaust their SNF benefits can receive a renewal of SNF benefits under the waiver if it is related to the emergency, meaning they've had a 60-day break. They have not had a 60-day break in skill from when they have exhausted benefits. So it's not that somebody came off of Medicare on day 45 and they get a new 100 days because now they're COVID positive within that 60-day period of wellness. If that happens, the 3-day qualifying stay hospital waiver, 3-day qualifying hospital stay waiver will come into play. And then they're just going to continue where they left off. So they're going to start on day 46 and continue on. What this benefit period waiver is if they've exhausted benefits, they're in and they've dropped skill, so they're no longer receiving a skilled service, and they're waiting, they're in the middle of getting that 60-day period of wellness to get a new benefit period, and something happens that is related to the emergency. It doesn't say that they have to have COVID specifically directly, but they have to be in some way related. This coverage needs to be related to the emergency in some way. So that allows them to not have a 60-day period of wellness and access their another up to 100 days of benefit. This also applies for somebody who maybe has not broken skill, and on day 100, they have COVID and they are affected directly by this emergency because on day 100 of their stay, they're still dealing with skilled services related to COVID and the public health emergency. At that time, they can also have a new benefit period for up to 100 days without having to even have a break. So they can go on day 100, be one benefit period, and on day 101, that actually will start a new benefit period. And everything kind of stops at that period in between. So there has to be a final claim sent by your billers, which is a type of bill 214, with the 100th day being that original 100th day. Everything stops with that. And then starting on day 101, that's really now day one of your new benefit period, as if they had a 60-day break in skills care. They now have a new benefit period. Now they have a 5-day. They have to have a new 5-day. They have to have a new variable per diem calculation resets, their copay calculation resets. So they get a new day 1 through 20 at 100% pay. And then they also would have to have new certification. And then they're going to have a claim that indicates this is their initial claim, or depending on when they come off of Medicare and the time frame of your claim period, could be an admit to discharge claim. So a 211 or a 212 type of bill. So this is very different. And this particular document, because there has been some issues with billing related to billing this benefit period waiver, this document gives you some detail further down. And if you're looking for it, as I said, it's the Medicare Learning Network SE 20011 from November 9th. And it gives some details about how to do that billing. And because there's been some issues because people are very confused. This is very different from what we've ever done before. So it's definitely some additional work that your billers would have to use. Where this would not be appropriate is if the reason why they were still being skilled was completely unrelated to the emergency. So for the example that it gives here, if they continued their skilled care from day 100 and beyond, such as, the feeding tube, or they're getting 5 days a week of therapy, or they have a skilled, daily skilled wound care, or whatever it is, if it is completely unrelated to the emergency and the emergency has nothing to do with the reason why they're currently receiving this skilled level of care, then they are not going to be eligible for this waiver. It has to be something that is related to the emergency in some way, shape, or form. And you have to prove that. So you have to use that criteria when determining, can we use this benefit period waiver? If this wasn't a public health emergency, would we still be providing skilled care for this condition? And if the answer is yes, and it's unrelated to the public health emergency, then they're just going to be at a skilled no pay level. They're not going to get their 60-day period of wellness, and they may or may not get a new 100 days of Medicare. Another thing to note with this is you can only get one additional benefit period using the benefit period waiver. You're not going to get multiple. So it's only one additional 100 days for that 100-day, that 60-day period of wellness benefit period waiver. If they have a new 60-day period of wellness, you're not using the waiver because you've met your criteria for getting a new benefit period the old-fashioned way, and perfectly appropriate. So you could have had somebody who exhausted benefits ages ago, maybe back in March. They've now had a 60-day period of wellness, and maybe they're sick with COVID now. They're at a skilled level of care. Maybe they got hospitalized, or maybe they didn't. You can utilize the 3-day qualifying hospital stay waiver. You don't have to use both at the same time. So just because you use the qualifying hospital stay waiver, that is completely separate from the benefit period waiver, even though they kind of lumped it all together in the documentation. Unfortunately, skilled nursing got a very small section in all of this document, got all the documentation, the frequently asked questions and all of that. It's really focused on other provider types, and we just got a little bit compared to the rest of it. So it's made it kind of tricky because they've kind of bunched all of the information and waivers into one paragraph. That qualifying hospital stay and the benefit period waiver are crammed into one paragraph. So it looks like they have to meet the same criteria, and that is not true. So this document hopefully clears it up a little bit related to when you can access it. And certainly there are other waivers in place related to the current emergency. And this is one of those that was most recently updated on 12/1/2020. More information about the blanket waivers. Nothing has changed for our setting. Let me make that bigger, not smaller. So the nice thing about how CMS updates things is they'll put things in red so you can see what the changes are. The only thing that's changed with our setting is the staffing data submission terminated in June. So that was for the payroll-based journal where we didn't have to submit the staffing data. So that is no longer a part of the waiver, but all of the other information still is. So there still is a timeliness requirement that was waived, although that was kind of silly because everybody's been submitting MDSs because we still have to get paid by Medicare. We still have to get paid if you're case mix by Medicaid. So, sidebar to that, the 5-star ratings are going to be updated in January because they had the data. They didn't think they were going to have the data because of this waiver, but they do. So they're now going to be updating the 5-star rating in January based on data that they didn't think that they were going to have, but turns out they did. So it's going to be very interesting to see what our 5-star ratings look like with all of this data from the beginning of this pandemic. But this is another nice document. There's also a frequently asked questions document out there that speaks to some of these different waivers, but not every question is answered, unfortunately. So these were some of the bigger things related to the pandemic. But the documentation is there. Like I said, it kind of is confusing because a lot of the different entities, like you're hearing one thing from one group and maybe a different interpretation from another group. And there's a difference of opinion on the ability to access some of these waivers. But basically you have to take that information and apply it to your facility and be consistent. And if there's any question, if you've received any guidance, if you've reached out to your state RAI coordinator, if you've reached out to your MAC, if you've reached out to any folks at CMS, those are good emails to hold on to, because if there's any question about it when you actually go to bill or maybe get reviews from your Medicare administrative contractor, it's good to have that reference and always have your reference materials available because I think there's a lot of different interpretations out there. So those are the two big questions that came in since last session. And we do have a few minutes left. I don't know if there's any questions have come in. Doesn't look like it. Or if anybody's interested in raising their hand to shout out a question to me, I'm happy to.
And we don't have anything in chat, Jennifer.
Okay. Well, it certainly has been an upside down and crazy several months. Hopefully the end is near. But unfortunately, the world of MDS continues to spin. We've talked about before that these waivers have nothing to do with the instructions in the RAI manual. They have not updated instructions in the quality measure manuals related to the waiver. They've done some adjustments to when they're calculating things, and they've put, freezes on, the 5-star temporarily, and the freezes on the staffing measures and those types of things. But as far as the actual definitions are concerned, nothing has changed. So we still have to meet all of the criteria that is listed in the RAI manual. We can't just assume that because we're in a public health emergency that, we can all of a sudden code isolation because they're both COVID in one room. If they're not in a single room, you can't code the isolation. They have to meet all of the criteria. And same with all of the other parts of the RAI manual. There's been no special changes. Any changes that were supposed to come out October 1 were put on hold because of, obviously, the bigger fish to fry was COVID this year, because there was a lot of pretty major changes that were coming to the REI manual that were put on hold. And certainly several states in the nation had to add PDPM completion to their OBRA assessments. So that kind of put an extra burden to those folks, in addition to any additional craziness they had with COVID. And there was some discrepancies because the information in the REI manual isn't based on completing this with an OBRA assessment. It's all based on completing this with a Medicare assessment. So there's not real clear guidance. And CMS has said, well, we're not going to provide clear guidance because it's state specific. Not every single state is requiring it. But the problem is, once they do make the updates to the REI manual that they were originally intending, they were going to take section G out of the federal requirements. But a lot of our quality measures are based on section G. So that means they would have to switch the quality measure calculation if they were going to be looking to have similar quality measures like the decline in ADLs and the decrease in dependence with the locomotion. They're going to have to recalculate and recalibrate how they calculate those quality measures. And if we're not all doing section GG the same way, that's going to have inconsistent data for their quality measures. So there's a lot of question marks out there. And it'll be interesting to see how that all plays out once they actually make the changes in the REI manual. If they'll do it next year or maybe hold off, I think it's going to depend on where we are as a nation with the current emergency. A lot of the things that were put on hold, some of them were related to being 2 fiscal years out of the public health emergency. So once it's declared no longer a public health emergency, some of the items aren't going to be affected until 2 fiscal years after that. So it could, timeliness could have the impact, but we just have to be aware of our regulations and still follow what they've set forth and get on all your listservs so you get all those updated manuals and change requests and articles and things that are out there, so we stay aware of all of those changes. Still quiet in the chat?
Still quiet, Jennifer.
Okay, not a chatty group, but hopefully the information is there, and where I'm always available, even after this session, independent of what you do with, any further contracts. I'm always happy to help. I love answering questions. That's part of the fun, is helping people learn and understand and know where to go to get it. So we're all on the same page. We got to fight together. So we're all looking at things the same way.
There is one question now that came up. Will there be notes for this call?
I think other than just the recording, I don't have anything in particular. I don't know, Mary, if you had anything other than just the recording that would be available.
No, the recording will be posted on the website.
And Shauna Gilbert wanted to say thank you.
You're very welcome. Happy to be here and help. And some of you may, oh, go ahead.
No, Katie says the recording will be perfect.
Oh, perfect.
Okay.
So I think I'd mentioned last time, I am going to be doing some virtual certifications through the American Association of Nurse Assessment Coordination, where I'm the master teacher. So that's what those letters are. So RAC-CT or RAC-MT is I'm a master teacher for their certification and advanced certification courses, and CRC is I'm a certified risk coder for ICD-10. So those are my big hooplas. But I'm doing a bunch of trainings. Many of you probably have received my flyer, because I've heard from even folks from Hawaii have gotten it. So it should have gotten to all of your facilities, and I'll also be sending out some information to the Mountain-Pacific folks, and they'll be sending it to you electronically as well. And I love to see you again in Zoom land at a future certification.
Moira Fish also wanted to thank you, says she always learns something.
Oh, good. I see that it's 3:31. So I guess I want to say thank you for everybody tuning in, and I'm so happy to be here as a resource to you all. And thank you for having me.
Thank you, Jennifer. It was great. Really
Yeah.
great.
Awesome.
Terrific. Katie and Christine Yavis, both of them said thank you all.
Happy holidays, everyone. Thank you.
Happy holidays. Stay safe.